You better come down here. So while Pam's coming down, we'll just take a few minutes because as Michael and Philip have said, it is a couples issue. And in Pam and I, you've got just one couple that's prepared to talk about these things. And we've been around for a long... Come around here, Pam, right?
In the spotlight.
And it's important for us to be able to talk about these things openly. And the great benefit of support groups and what we do is we link like people up in their particular journey. So in support of the doctors, we're part of the food chain. We can actually give and listen to people going through these issues and give our practical experience relating to their issue. We don't give advice, but we can listen and demonstrate that the things they're going through, we've all gone through. Now, in my own case, without boring too many people, but I'm 68 today, and when I was 51, I was diagnosed with prostate cancer. And we went through the same dramas that everyone else has, and we were very lucky. The early diagnosis proved to be a godsend to us. So what we've done in the following years is we've tried to put a little bit back and make sure that quality of life for couples is a really important thing, and that's where we focus a lot of our attention. Now, again, in my case, I was one of the very lucky ones as far as incontinence was concerned. And I did the pelvic floor exercises beforehand, and they did work. And after 6 weeks, I went back to work on the 7th week, and I wore a pad just for safety. But in those days, it was Pam's napkins that I used to borrow. Well, I say borrow, but I didn't give them back. But now they've made it easy for you modern men because the pads are male pads, because the ladies' pad needs to come from below and the male pad needs to come from the front. So they've got that sorted out and make it easy for you. So all that worked. But the point that we want to make is that, as both doctors have said, people, it's quality of life, and people shouldn't put up with incontinence. There are solutions, and that's the message that Pam and I give people, that if the pelvic floor exercises don't work, seeing a specialist physiotherapist doesn't work, then a sling is an option. And of course, we've spoken to hundreds, thousands of people in this time, and we find that the slings work in a lot of the cases, as Philip has described, but the artificial sphincter is the gold standard, and we have not met one person, which is quite a statement, an absolute statement, who has been dissatisfied with an artificial sphincter. We see in our support group network that a man can be turned from wet to dry by the artificial sphincter, if that's the last course of action that is taken. So our message is, from a patient and a carer's point of view, and part of the support group network of the Prostate Cancer Foundation, is that quality of life is important, and these remedies should be spoken about openly and followed through. So that's the incontinence side. Do you want to add anything?
No.
I'm doing all right. Just give me some encouragement, Pam.
No, it doesn't need any.
So we get to the erectile function. You'll notice Pam's glasses at this stage fog up. No, not. So we back in those days, we were fortunate that we had a urologist who told us about the possible side effects, and we did exactly what he suggested. And early in the piece, we stimulated the penis with injection therapy. There was no way in the world I could have said that I'd inject my penis, but the urologist showed me what to do, and I was able to do it. But the first time it happened was in his office, and then I said, well, let it down. And he said, well, you've just got to go home and use it. Well, we had the painters in. And fortunately, mobile phones were around then. So I rang Pam and I said, I'm coming home. She said, aren't you going back to work? I said, no, I'm coming home. She said, why are you coming home? I said, because I've got an erection and we need to use it. And that's what the urologist suggested. So I can't let him down, and it wasn't going down. So anyway, we persuaded the painter that I was feeling ill. Pam had to come upstairs and lay beside me because she was worried about me. Anyway, that all worked, and it is very successful. And a lot of people we know that we talk to in the support group network use injection therapy. They have done right from the very beginning, and it's very successful. In between time, we use the vacuum device, and
Excuse me, if you want to talk to somebody that's using penile injections, the man that gave out the parking tickets is the fellow you want to talk to.
Young Ken up there somewhere. At any rate, Michael was quite right. The vacuum device does work, and you can have good sex. But the way he described, I thought I was pretty good at describing, but he takes the cake. And Pam can also confirm that it is a cold penis, and it lacks direction. Now, I would argue that there's a good thing about that because it needs help. But we use the vacuum device for quite a time, and one of the best parts of the vacuum device, apart from having good lovemaking ability, was that going through customs and explaining what this thing was, I loved that part of it as well. But the way we use the injection therapy and the vacuum device is we would go to bed and start the lovemaking process, and then if I...
Too much detail?
No. And then if I was going to... whilst I was on the injection therapy, I'd go into our walk-in wardrobe and I'd have everything set up and I'd inject myself, and then I'd slide back into bed and we'd make love, and it worked. The same thing with the vacuum device, and one of the things that's a tip if you are using the vacuum device is just liken that ring at the end of the penis to a lamb's tail ring, because if you leave it on too long, it's not good. But if I had my time again, and I think, and hopefully Pam's going to confirm this, I would have gone for because in my case, there was no way anything else worked other than the injection therapy and the vacuum device, so the oral medication didn't work. So again, if I had my time again, I would have gone to the penile prosthesis a lot earlier than I did, because now we go through the same lovemaking process, and Pam says, pump up. So I used to say I go downstairs, and some people misunderstood me and thought that I actually left our bedroom on the first floor and went to the second floor downstairs. But what I meant to say was I go down to the scrotum and I pump up. And then we make love, and then Pam says, well, I'm happy, you happy? And I say, yes, I'm happy. Well, let it down then. So I go back down there and press a button, and it comes down. And really, we're talking about quality of life, and we've got to be able to talk about these things as couples. It's the best thing since sliced bread. And as I said, I'm 68 and Pam's 66. I get into trouble for saying she's in her 67th year, but that's not a good thing. But we enjoy our lovemaking as much as we did. We've been married for 45 years. So what we're saying is backing up what the two doctors have talked about. And it is really important, as they have also mentioned, to talk to people like us who have practical experience in all these areas. And we've got support groups now, as I said, 148 of them, soon to be 150, in every state and territory in Australia. So Pam, do you want to correct anything?
No, I don't want to correct anything, but I think you can now see the value of being involved with a support group, and I hope more of you will come along to the one closest to you.
Right.
Yes, I was interested in what Dr. Gilman had to say. There's two questions I have. The scarring. How long post-operative in a radical prostatectomy does scarring set in? Yep. And is it irreversible once it's set in? And two, neither of you have mentioned the effect of a radical prostatectomy on bowel action. What's known about it and what can be done about it?
I'll take the first part. You can talk about the bowel bit. Firstly, it depends on a bloke's normal erections before the surgery. You've got to remember that a lot of men, when I see them, already have some of this fibrosis occurring. Why does a baby, when it's first born, why does it get 6 to 8 erections every night during rapid eye movement sleep? Well, this is penile aerobics. Right? This is how the penis actually oxygenates. At the other times when the penis is flaccid, there is no fresh oxygenating blood circulating through the erectile part. So we need to get these, and if you don't, you start to get these little strands of fibrin and collagen, little scar tissue strands through it, which is what the fibrosis is. Now, we think that it may occur within around about 4 to 5 months of no blood coming through, so 4 to 5 months. But many men already have some fibrosis beforehand because they had erectile dysfunction. So we want to get the aim of this is we want to start as soon as possible, and that's why we choose the 4 to 6 weeks after surgery, or after the catheter comes out. That's when I see them, and Philip backed that up with what he was doing there. So then the second part, is it reversible? Well, the answer to that's actually yes. What we do know is that men who have some erectile dysfunction and they're not getting erections in the morning, etc., and we treat them. We treat them whether with injections or tablets or whatever, and we start getting the blood flushing back through. There are men who will actually start to get the return of their erections again. Now, how could this be? From the reoxygenation of the blood coming back through the penis. And we believe that reoxygenation increases the prostaglandins in the penis. So therefore that stops this ongoing fibrosis. There's a thing called transforming growth factor, beta 1, which actually lays down collagen and fibrin. And the antidote to that is to get your prostaglandin levels up. And how do you do that? By reoxygenating the tissues of the penis. So the answer to your question is yes. However, you will get older. You may have high blood pressure, you may have an increased waist circumference, and all these other things going on in the background which are working against us. But to answer your question, theoretically, yes, and probably about 4 to 5 months after surgery is when we would see that. Now, the bowel bit.
There was a paper some years ago suggesting there was a 5% incidence of fecal incontinence after radical prostatectomy. And that caused a big stir amongst urological circles, and it wasn't reproduced. And I must say, in my experience, I've not seen that. And when I go overseas to conferences, we talk about all these things. Very few surgeons report this. So do you have a particular experience with this or knowledge of it? I would say, generally speaking, there's no reason why radical prostatectomy should affect anal sphincteric control.
It's a change that I've noticed in bowel action, in that the matter doesn't seem to move from the upper bowel to the lower bowel.
I misunderstood your question. It's more a change in bowel habit tending towards constipation.
Yes.
Yes. Now, I wouldn't attribute that to radical prostatectomy. I would suggest it's more coincidental. There are no nerves to the rectum damaged by the surgery. And as for the surgery actually causing fecal incontinence, I've not seen it in over 25 years, and I really don't believe it happens.
In our March-April newsletter, we had featured a report on bowel incontinence. Jenny Rex from the RPA hospital came out and gave a fantastic presentation. She's on DVD if you want to go into the PCFA website and find the YouTube. No, but it's how your bowel action occurs, and it gives a great explanation on everything that you probably need to know.
I mean, just in summary, I would say that it's not due to your surgery, and you should address the issue in its own right. And not speaking specifically to you, but generally, any adult with a change in bowel habit that is persistent, should have a proper medical assessment, colonoscopy, to be sure that there's no significant underlying disease. Otherwise, of course, the high fibre diet, the exercise, the plenty of water, all of these things are very important.
Yes, Michael, it's in your direction, really. I have been through terrible depression, and that was created by, obviously, this business of, well, you were just not continent, and it got to, you couldn't climb a ladder, couldn't mow the lawn, you got wet feet, but not from the grass, it was from yourself. And both of us went through this depression thing, and we got onto a medication, and that medication has had a bit of a double whammy for me, and I don't know if much is done about it, of calming the bladder, because I spoke about it to a few physiotherapists, and they said, oh yes, we use it for women to calm the bladder. It's a serotonin-based medication. Is it known as a common thing to help men with their continence problems?
Which drug are you talking about?
Eleva.
Okay. With Eleva, as you know, that is an antidepressant medication,
yes.
And so that's why you're saying you would actually have a double effect there, you know. There is no doubt that when I see men who have not gone through the rehabilitation, etc., they almost go through like a post-traumatic stress disorder, if you like. Everything, when a bloke first gets diagnosed with this, there's something to do. You've got to go and see the urologist, you've got to see this, you've got surgery booked in, there's all these activities that are planned up, and blokes do all these things. Then the surgery's done, and then everyone suddenly, it's all finished, and reality sets in, and that's when this post-traumatic stress disorder almost can take over, and people can get quite depressed with that. They've had a brush with mortality, etc., etc. Now, as far as calming the bladder down, you know, there's a range, and I'll actually let Philip talk about this, because there's a range of medications that actually have been used to change the tone of the sphincter of the bladder, etc., etc. And all of these are used in urological practice and in my practice as well for people who have these bothersome lower urinary tract symptoms. However, there are some men who will get this purely from an increased anxiety, increased adrenaline which is being produced, which can all be part of the anxiety depressive type disorder that you're describing. So is it possible, therefore, that we could actually use something that alters the serotonin, that alters the level there, and that has an effect on the bladder? The answer is absolutely yes. But is there any serotonin receptors, etc., that are actually in the bladder where this lever thing's working? And I don't believe that there are, or I haven't heard that there are. So it's actually acting centrally, and that's exactly what you're doing, is achieving both things with doing that. But we should not be underestimated, this whole bit about this depression and psychology bit, and Philip had this in his team of people that he works with. That hasn't been done a lot lately. It's always, let's fix it, we'll do this, 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 but what about the couple and the relationship and all that? And increasingly now we're using clinical psychologists, etc., as part of the team because it's well recognised.
David, can I just pay tribute? I've just spotted some of our very important team members here, our nurses from level 11, our urology nurses. I can see Jane and Mina, and maybe there's some more there. These ladies do a fantastic job nursing our men who've had radical prostatectomy, so let me just publicly acknowledge them. Yes. And I've just spotted Mrs. Libby King too. Thank you for coming, Libby. Libby's our urological nurse and counsels a lot of men and helps them through their whole experience. So these ladies are very important to our whole treatment programs.
There was a device out on one of the tables called a Bathmeet, and I'm just wondering if anyone's had any, if anyone's used it as far as exercising the penis during that period of time of the 12 to 18 months when you're waiting for the nerves to recover.
I actually don't know too much about it, Colleen. If you want to get a brochure on it, I'll get you one. So, if you...
Oh yes, I've actually got one for the support group, but I really would like to know someone who's used it and whether the specialists feel that you know, when would be a suitable time for the men to start using it. Is there any danger with it? Can they start using it within a couple of months of surgery? It's not going, you know, if it's going to.
Is it a vacuum-based device? Yeah. Okay.
Yes, it is.
I think well, from my point of view, we did cover that in the talk there. I think it will give you an erection. Does it actually help as far as the whole rehabilitation process? If it did, it would be from stretching the tissues there to actually try and preserve some penile length. So that would be where it's coming from. But you know what I'd rather do? I'd rather actually get the blood coming through from the arteries. I would still get the same thing. I would still strengthen the thing out, get the same length and all of that. And I'd be getting fresh arterial blood and fresh oxygenated blood into the penis. From my point of view, I would rather that the patients actually got 2 to 3 good arterial erections a week rather than substituting one of those with a vacuum-induced one. But would it do any harm? Well, I'll let Philip. I would have thought no. Maybe.
Find its use as a tissue expanding device to be quite useful prior to implant surgery, but not as mainstay primary rehabilitation.
And I do have one other question. I'm just wondering how long after radiation can an implant be done?
It can be done almost immediately. There's no reason why it can't be.
In relationship to the penile prosthesis, there doesn't appear to be much literature about the removal of one and the complications that are there for people that have got one. It's totally useless.
No, there's a lot of literature about that. The main complications of prosthetics is infection. These days a very low rate, but that is the complication. Now, previously we used to automatically remove an infected prosthesis. These days we have a salvage protocol which involves on the table removing it, thoroughly washing the tissue with antibiotic solution, reinserting a new device and giving a month of antibiotics post-operatively. Using this salvage protocol, we are able to salvage about 70% of men with an infected prosthesis. For those in whom it doesn't work, we take it out and insert a further device if the patient wants it 3 to 4 months later. In terms of mechanical failure, these days that is a rare event, and if it does happen, revision surgery can fix it in virtually all cases.
Yeah, I'm interested in locating the literature that supports that so I can do some research on it. Thank you.
Well, it's all there on the internet, the good and the bad. I'm not quite sure what your exact question is. Well, it can fail for mechanical reasons in rare cases, but the way to fix that is to revise the device, which is not difficult to do.
If there's no more questions, we'll finish up right on time, and it remains for me to say thank you to everyone turning up and making tonight a meaningful night for a whole lot of us. I'd like you to help me thank the two doctors, Dr. Michael Gilman and Dr. Philip Catlaris.